We are live now, ma'am. Sindhuja, ma'am, please start.
Kundavi, ma'am.
Yeah. It's my pleasure and my privilege to introduce our president, Dr. Sharad, to give the welcome address. Over to
Thank
Dr.
you,
Sharad, sir.
Yeah. Thank you, Dr. Kundavi. Yeah. Thank you. Welcome you all for today's Journal Club meeting of Tapisar and and I'm thankful to Dr. Kundavi and Dr. Sindhija for successfully conducting these Journal Club meetings on regular basis. And I once again thank Dr. Kundavi for selecting today's topic on alcoholics. I heard many talks on alcoholics. They're all concentrating on pain management in endometriosis. No? Whereas today's topic, alcoholics being the for down regulation of pituitary gland in ovarian stimulation protocols, which will interest us for all the infertility specialists. No? So because one being orally active, and it will be convenient for the patient, and it will be cost effective also. So I'm really thankful to Dr. Kundavi for selecting this topic, and I'm thankful to
Dania.
Dr. Sumana from Apollo Hospitals, for enlightening us on this topic. Okay. Then coming to Dr. Sindhuja, you have selected the DNA fragmentation and IVF success rates. It's such an important topic because we all have realized that oxidative stress is an important cause for male factor infertility because sperm has scanty cytoplasm compared to the oocyte. Oocyte has abundant cytoplasm with plenty of antioxidants, whereas sperm has scanty cytoplasm with less amounts of antioxidants, and they're more prone for oxidative stress. This oxidative stress will affect all the components of the spermatozoa, like lipid peroxidation or mitochondrial dysfunction or DNA fragmentation, which will affect the fertility of the man. So, and Dr. Rajapriya is going to enlighten us with her expert comments on this topic. And I welcome you all once again, and I request Dr. Kundavi to take it forward. Dr. Kundavi, please.
Sindhu? Sindhu, introduce the speaker, the chairperson, Sindhu.
Yes, ma'am. I'd like to invite the chairperson for the first session, Dr. Aishwarya Tapisar, ma'am. She's a consultant gynecologist and fertility specialist, currently lead at Prashant Fertility Center, Ambattur, and Acumed Specialty Clinic and Scans, Valsaravatham. She has an experience of 10 years and she's from KMC and AIMS and worked at JIPMER, and she's done her FNB exam at MMM Chennai, and she's also done her MRCOG. Aishwarya ma'am, I kindly request you to introduce the expert and the topic and the speaker for today's session.
Okay, thank you, Dr. Sindhuja. I'm extremely delighted to welcome Dr. Sumana Manohar ma'am, Senior Consultant and Coordinator, Department of Obs and Gynec, Apollo Women's Hospital. She has a subspecialty interest in fetal medicine, endoscopic surgery, and high-risk obstetrics. She is the chair of South AICC RCOG and is also a Part 3 examiner. Scientific Chair EPAGI 2024. She is a very well-known face and invited faculty at national conferences and has several publications in national and international journals. Thank you, madam, for accepting the webinar. So today's topic is going to be...
Thank you.
So today's topic is going to be the role of elagolix in ovulation suppression during the controlled ovarian stimulation. And it is a retrospective cohort study which is published in Fertility and Sterility. It is a very nice paper on a very current topic, and it is going to be presented by Dr. Danya Sharmugapriya. Over to you, doctor.
Yes. Can you share my screen, ma'am?
Yes, Dr. Danya.
Good evening, all. The article that we'll be discussing today is the role of elagolix in ovulation suppression during controlled ovarian stimulation. a retrospective cohort study. This study was published in Fertility Sterility Journal on 4th December 2024. So coming to the objective of the study, it is to compare the IVF treatment outcomes for the oral GnRH antagonist elagolix to the conventionally used injectable GnRH antagonist ganirelix for achieving pituitary suppression during a controlled ovarian stimulation cycle. So coming to the introduction, during a controlled ovarian stimulation in IVF treatment, it is necessary to suppress the LH to prevent a premature LH surge triggering ovulation before planned oocyte retrieval. So for the pituitary suppression, gonadotropin releasing hormone analogs like agonists and antagonists are used. So the GnRH antagonist can inhibit gonadotropin secretion immediately and reversibly through a dose-dependent competitive inhibition of the pituitary GnRH receptors. Thus, GnRH antagonists can limit pituitary suppression to only the days during which a premature LH surge is most likely to occur, precluding the need for the long downregulation protocol of the agonists. So coming to the drug elagolix, it is a second-generation GnRH antagonist. It inhibits endogenous GnRH stimulation of pituitary gonadotropes by binding competitively and reversibly to the GnRH receptor in the anterior pituitary. The effect achieved is a rapid suppression of LH levels and FSH release, which in turn decreases the production of ovarian estradiol and progesterone. The route of administration is oral, and the median time to a maximum plasma concentration ranges from 0.5 to 1 hour, and the half-life of the drug is 4 to 6 hours. It is metabolized mainly in the liver, and 90% is excreted in feces. The dose used in this study is 200 milligrams twice per day. Elagolix was found to achieve rapid and reversible pituitary suppression by a maximum inhibition of LH secretion in 4 hours. It returns to baseline in 24 to 48 hours after the last dose. It is approved by the US FDA for the treatment of endometriosis-induced pain. So the advantages of elagolix is that it is as effective as ganirelix in ovulation suppression in controlled ovarian stimulation, and the cost factor being one tablet priced at ₹90 and being 200 mg twice a day, but the expense for a day would be ₹180 versus one injection of ganirelix is ₹3,600. It is non-invasive, avoids multiple injections, it is painless. So the materials and methods are, it's a retrospective cohort study conducted at a private fertility center in Canada, approved by the local research ethics board. The sample size is 194 patients with infertility undergoing controlled ovarian stimulation. So there were 71 patients in the study arm who took elagolix tablet and 123 patients under the control arm who got the ganirelix injection. So the study period was from January 2022 to September 2022. The outcomes measured were the demographic characteristics, embryology, and the clinical outcomes. So the inclusion criteria were patients with infertility aged 23 to 50 years, BMI ranging from 15 to 42 kilograms per meter square, having received either elagolix or ganirelix alone for pituitary suppression during the controlled ovarian stimulation cycle. The exclusion criteria were the patients outside the age range defined in the inclusion criteria, patients who received neither or both elagolix or ganirelix, patients who were receiving either elagolix or ganirelix for a reason other than controlled ovarian stimulation. So the primary outcomes measured were biochemical pregnancy, sustained implantation, cycle cancellation rates, and the secondary outcomes were miscarriage rates, fertilization rates, and blastulation rates. So coming to the method, first with the pituitary downregulation, on day 3, tablet clomiphene citrate 100 mg was given for 5 days along with daily injections of recombinant FSH, the dose being 200 to 325 international units per day based on the age, FSH, AMH, and AFC. Serum estradiol levels testing and ultrasound monitoring was done on day 7 and then at 3 to 4 days interval to guide the FSH dosing. When a lead follicle of 14 mm or greater was observed on ultrasound, pituitary suppression was initiated. Study group received tablet elagolix 200 mg orally 2 times per day, and control group received ganirelix 250 micrograms subcutaneously every night at bedtime. Trigger: once the follicle maturity was reached as indicated by the estradiol levels and follicular number and size, elagolix or ganirelix was discontinued 24 hours before the GnRH agonist decapeptyl 0.2 mg or eucerin and a HCG trigger 10,000 international units was used to induce ovulation. Oocyte retrieval was performed 36 hours after the trigger injection. So endometrial preparation for frozen embryo transfer, hormone replacement therapy was adopted for the endometrial preparation. The protocol was initiated with the oral estradiol 4 mg 3 times a day beginning on day 2 to day 5 after the transvaginal ultrasound scan. After a second ultrasound scan was performed and serum estradiol and progesterone levels were checked, the dose of estradiol was adjusted accordingly. So luteal support was initiated when endometrial thickness was more than or equal to 8 mm and serum estradiol and progesterone levels were optimal. Luteal phase support was achieved with oral progesterone 200 mg 3 times a day and intravaginal micronized progesterone suppositories 200 mg 3 times a day. Progesterone supplementation was continued until pregnancy was confirmed at 10 weeks. Embryo vitrification and thawing followed the Kidzato protocol. Embryos were thawed the morning of the transfer and moved into organ culture dishes containing 1 ml of culture media to be cultured for 3 to 4 hours awaiting the transfer. The embryo transfer procedure was performed. PGTA, the embryos were hatched using a reproductive instrument, a Saturn diode laser on day 3 of culture to allotrope for ectoderm herniation by day 5 or 6, after which the biopsy was performed. Biopsy samples were processed for DNA amplification, which was performed using a PCR. Chromosomal copy number analysis was performed using NGS using the Illumina MISCQ platform performed at the in-house genetic laboratory. So the reproductive outcomes measured were fertilization rate, the number of fertilized oocytes divided by the total number of mature oocytes inseminated. Blastulation rate is the number of blastocysts generated divided by the total number of fertilized oocytes. Biochemical pregnancy per embryo transfer is the positive serum beta HCG level confirmed 2 weeks after the embryo transfer. Sustained implantation rate per transfer is the number of pregnancies with fetal heart rate in ultrasound at 7 to 9 weeks divided by the total number of embryo transfer. Miscarriage rate per biochemical pregnancy is the proportion of patients who had a positive biochemical pregnancy test but did not show a fetal heartbeat on a 7 to 9 weeks ultrasound. So the statistical analysis used here were the continuous variables were presented as means. Differences between the groups were assessed using student or Welsh t-test and Mann-Whitney u-test. Categorical variables were expressed as frequencies and percentages within the groups were compared using Pearson and Fisher's exact tests as appropriate. P-value of less than 0.05 considered statistically significant. Relative risks with 95% confidence intervals were calculated. So coming to the results in the group demographic and cycle characteristics, the number of cycles, it was 71 cycles in allogolics and 123 cycles in ganirelix. The cancellation rate were 5 cycles in allogolics and 6 cycles in ganirelix. The mean FSH was 7.6 in allogolics and 7 in ganirelix. Mean progesterone at HCG trigger was 1.4 nanograms per ml in allogolics and 7 nanograms per ml in ganirelix. The mean peak estradiol levels were statistically significant. It was lower in the allogolics group than the ganirelix group, and the mean peak LH was similar, 7.1 international units per liter in allogolics and 7.2 in ganirelix. So the mean BMI was 26.9 in allogolics and 26.2 in ganirelix. The gravida and the pregnancies and the deliveries were similar in both the groups, and the mean age group was 35.4 in allogolics and 36.1 in ganirelix. So the statistically significant values were the serum estradiol levels, which was lower in the allogolics group compared to the ganirelix group, and the primary cause of infertility was PCOS and tubal factor in allogolics. So coming to the embryology outcomes, the mean oocytes retrieved were similar in allogolics and ganirelix, being 12.7 and 12.4, and the fertilization rate and the blastulation rate were similar. It was higher, 84.4% in allogolics and 81% in ganirelix, and the blastulation rate was 60% in allogolics and 63.9% in ganirelix. So the cycle cancellation in allogolics, we had 5 cycles cancelled, of which 4 cycles were due to poor response to ovarian stimulation and 1 cycle due to the premature ovulation. In ganirelix, we had 6 cycles cancelled, of which 4 were due to poor response to ovarian stimulation and 2 due to premature ovulation. So coming to the clinical outcomes of the frozen cycle, the biochemical pregnancy rate per embryo transfer was statistically significant in the frozen cycle. It was 74.5% in the allogolics group. And the others, like sustained implantation rate per embryo transfer and miscarriage rate per biochemical pregnancy, was similar between the groups. In the fresh cycle, the biochemical pregnancy rate, sustained implantation rates were similar, but the miscarriage rate for biochemical pregnancy was 0 in allogolics group. So of the 51 patients in the allogolics group, 13 underwent PGTA, of which 11 were euploid And in Ganirelix group, 30 underwent a PGTA of the 93 patients, and 26 were euploid embryos. So coming to the discussion of the group demographic and cycle characteristics, the study and control groups did not differ in their baseline characteristics. Elagolix group had a significantly lower peak estradiol levels than the Ganirelix group, and this was because the dose of the elagolix for this group was 200 mg twice daily, higher than the dosage used in the previous studies. Okay, so this is the previous study. This was done in the donor oocyte cycles where they had given elagolix 200 mg once a day dosing, and the average peak estradiol was 3959, which was higher than the Ganirelix group, and the cumulative gonadotropin dose was also higher in the elagolix group. But the peak LH levels were similar, 0.9 and 1.3 in the Ganirelix group. So to bring about the suppression in the reduce the peak estradiol levels, the dosage was increased to 200 mg twice daily in this study. The gonadotropin dose required in elagolix group was lesser compared to the Ganirelix group, and the mean peak LH suppression was similar in elagolix and the Ganirelix groups. So coming to the embryology outcomes, there was no difference in the number of oocytes retrieved, fertilization or blastocyst development rates, and number of embryos transferred between the study and control groups. So coming to the clinical outcomes, the cycle cancellation rates were similar between elagolix and Ganirelix groups. When examining frozen embryo transfer, the elagolix group's biochemical pregnancy rate was significantly higher. This difference was not observed for patients undergoing fresh embryo transfer. The sustained implantation rates were similar between the elagolix and Ganirelix for fresh and frozen ET. And then elagolix group displayed a decreased miscarriage rate with the fresh embryo transfer. And in frozen embryo transfer, the groups were similar in this respect. So importantly, the utilization rate of the PGTA was similar in both the groups, with a similar percentage of these patients having euploid embryos transferred. Moreover, the biochemical pregnancy rate across all frozen embryo transfers seemed unaffected by the use of PGTA, which is found for patients above and below 35 years of age. These data suggest that the apparent improvement in biochemical pregnancy in the elagolix group undergoing frozen embryo transfer is not because of greater utilization of euploid embryos. So the one plausible explanation for the higher biochemical pregnancy rate in the elagolix group is the higher incidence of patients with tubal factor infertility and polycystic ovary syndrome in this group. Patients with these etiologies can be considered to have a good prognosis and would be expected to have better outcomes. Higher proportion of these good prognosis patients in the elagolix group could account for the observed improvement in biochemical pregnancy. So coming to the cost factor, one dose of elagolix one tablet is 90. If it is 200 mg twice a day, it would be 180, and for 7 days, it would cost around 1,260. Whereas Ganirelix, one dose is 3,600, and for 7 days, it would cost around 25,200. So total savings with elagolix would be around 24,000. So limitations of this study is that the lack of follow-up to live births, embryos were cryopreserved, and not all the embryos were used for transfer within the study time frame, meaning their input to the pregnancy rates cannot be considered. Data collected were from a single center, thus limiting the generalizability of the findings. Therefore, these preliminary findings must be interpreted cautiously and validated with large, robust, randomized clinical trials. So coming to the conclusion, the oral GnRH antagonist elagolix is as effective as the injected antagonist Ganirelix in terms of embryological and clinical outcomes, offers a patient-friendly approach to pituitary suppression for IVF treatment, and it is more cost-effective. So these were similar studies done in the past. The first study was Marco and Mary et al. In 2023 with 121 samples. They prescribed egolix at 50 mg every alternate days. There was LH suppression. There was nil premature ovulation, and the LH values dropped from in the egolix group were 42% in egolix group and 24% in the Ganirelix group. The other study was Bonafis et al. In 2023, where 150 samples of the donor cycles were studied, and they were supplemented with 200 mg once a day dosing of egolix, and LH suppression was found, and there were no premature ovulation, and the embryology outcomes were studied. And the last study is the one that we discussed right now, Soliman et al. The sample size was 194 and the dosage of Egolix was 200 mg twice a day. And LH suppression was seen, although Elagolix group had 1 premature ovulation and Ganirelix group had 2 premature ovulation. But there were lower mean estradiol peak levels and the embryology and clinical outcomes were studied. Thank you. These are the references.
Thank you, Danya. Basically, this study, we took it because the oral GnRH antagonists also have a role when the cost is the main factor. The cost is lesser. Yes, that's number one. And in this study, maybe the biochemical pregnancy rate was on the higher side because of the PCOS and the tubal factor in the frozen embryo transfers. And the other important thing is the estradiol level, actually. The estradiol level was less, I mean, it's not that suppressed when compared to the injectable, whereas LH was almost the same. So we need to know what is the right dosage to be used, either 150 or we should increase it to 150 twice a day or 200 twice a day. We have to improvise on that dosage schedule. But it seems to be a good idea to start using oral GnRH antagonists. Any comments?
Dr. Sumna, what about because it's not what can I say licensed no, for our the infertility purpose, but
Yes.
are we liable for litigation?
That I really don't know because I heard that SRMC is using it.
Okay.
Started using it. I don't know whether Sanjeev Reddy sir is around, but I'm not sure about it. It's not FDA approved for fertility yet.
Okay. Any comparison between this oral Elgolix and that progesterone primed this ovarian stimulation cycles? No? Any oral progestogen for down regulation of the pituitary? No? Any comparisons between these two studies?
I don't think. No, they have only comparing the injectable antagonists with the oral. They have not even compared with the agonistic long protocol. Also, they have not compared up till now. Yeah.
But quite interesting, Dr. Sumna, because cost effective and at the same time, no, we can take patient can take it orally, no? Yeah. Thank you. Thank you so much.
What about the safety of the drug?
Safety wise, it should be as safe as GnRH injectable. So basically, on the bone is the main issue. But other than that, because the half-life is on the lesser side, it comes back to normal levels within 24 hours to 48 hours. It shouldn't be, because it's going to be very short term. So it should not be a problem in the way.
Okay. And if they want, we can go ahead with the fresh transfers. Does not have an impact on the endometrium or anything.
No. In these patients, they have given double trigger actually. They have given HCG and also the GnRH agonist they have given. Maybe because they had more of PCOS patients. I don't know why exactly they gave dual trigger.
Dual trigger. We've started giving for 2 patients, PCOS patients, post egg collection in order to prevent the hyperstimulation. Just given 150 milligram for 5 days. And but we didn't have the guts to give only that tablet, so we gave a combination of antagon with these medicines luteal phase. So actually the patients didn't have any discomfort or anything. Just very 2 patients only we have tried, so probably we just thought we'll try with
ovarian stimulation to prevent
Yeah.
hyperstimulation. You have given, yeah.
Yes,
Okay.
yes,
Post egg
yeah.
collection. Okay.
Post egg
I think,
collection.
yeah, we can give the oral actually. That's what I was thinking. I think we can start using the oral GnRH agonist.
Yes, compared to antagon, the cost also comes down.
Mm.
So we've just tried for 2 patients, but it did work well. They did not have any pain or anything. So the symptoms have come down dramatically. So, but it only for 2 patients, but we just thought probably, for all freeze-all category, we can use it instead of giving the luteal antagon, the oral antagonist could be tried.
Yes, correct. Yeah. The dosage has to be higher. We don't get 200 milligrams tablets yet. We are only getting 150. at the moment in India?
I think, no, Sumna, I think the 150, 200 is available, but I'm not sure about the company other than Sun Pharma. The other guy is also brought with 200. Only
Oh.
thing is, these people are not giving us 5 tablets or something. The pharma is asking you to buy 10 tablets in a strip. Like letrozole for 5 days or something in the luteal phase. I just thought probably I can give 150 or 200 for 5 days. But the pharmacy is not allowing them to buy just 5 tablets. They say buy it as a strip.
All right. Okay.
Yeah.
I think 150 milligrams twice daily, we can give it confidently, not to prevent ovarian hyperstimulation syndrome. Yeah.
Yes, sir. I think it can be tried. Yeah.
Yeah, you can try. Yes.
Thank you, Dania, for excellent presentation. Thank you.
Thank you, ma'am.
Danya,
Thank
you did a
you.
wonderful job, Dr. Danya.
Thank you, sir.
I'll tell your sister. Thank you so much. Thank you.
Aishwarya, I'd like to add anything before we move to the next session.
Dr. Danya, it was a very nice presentation. All the senior people have given their point of views. I think, as rightly said, although it is very interesting, it's still not approved. So we have to have more randomized control trials for it to be used regularly. And sir asked whether there is any comparison study between PPOS and elagolix. Right now, there is no comparison, but the difference which this elagolix will give is it will allow a fresh transfer, which is definitely possible. On the other hand, PPOS, it is not possible to do a fresh transfer. And there is the live births have not been described in this study. So that is one pitfall of the study. And another thing is it has not classified into various subgroups, like how is the use in the poor responders, how is the use in hyper responders, whether cycle cancellation, which patient had undergone cycle cancellation, all those things was not this one. Maybe in the future studies, this can be tried. That's all.
Yeah, the other important thing is the previous studies, they used only 150. They used only 50 milligrams in alternate days. Even in spite of that, the LH level was decreased. So that also, I think it's not really dose-dependent suppression of the LH. That also we need to extrapolate, see whether it really need that much of medicine.
Like in PCOS, can we use this as a pre-treatment or something to bring down the LH, high levels of LH? In suppositories.
Yeah, that also is because it's really working on LH quite well. All the studies, I mean, Danya had 4 studies, all of them suggested it is even little dosage, like 50 milligrams in alternate days, also reduce the LH to quite a bit. So it's not a bad idea to use. I think it'll maybe by next year we'll have a consolidated data on that. Yeah.
Dr. Kundavi, even the basal levels of LH are high. We'll go ahead and start the stimulation with pure FSH. Most of the times, the LH levels will dramatically fall. No, I could observe that one actually many a time. No, so I don't think we should worry about the high LH values. No, before when we are starting the ovarian stimulation.
Okay, sir.
Thank you.
Yeah. Thank you, Dr. Sumana. Thank you so much.
Thank you, Dr. Tanya, Dr. Sumana ma'am, and Aishwarya ma'am. Sir, ma'am, can we move on to the next session, ma'am?
Yes, yes, yes.
So for the next session, I'd like to invite the chairperson, Dr. Vijaya Ganesh ma'am, who is the director of New Life Wellness Center, Alvapet, Chennai. Ma'am has done her MBBS in MMC and Masters in Genetics at Ramchandra and also her PhD in Human Genetics. She has been the organizing committee member for South ISAR and organizing secretary for TAPCon annual conference in Chennai and Embryology ISAR and UVA ISAR and ISAR annual conference Chennai 2015. She's been awarded the Dronacharya Award and she's the academic secretary for Tamil Nadu and Pondicherry chapter of ISAR. She's also been awarded the ISAR Rising Star Award and Best Doctor Award.
Thank you, Sindhu, for your nice introduction. Sindhu?
Yes, ma'am. Dr. Rajpriya's CV is displayed.
Yeah, yes. And thank you, Dr. Sarath and Kundavi, for Sindhu, for giving me this opportunity to be a chairperson for this session. And now I would like to introduce Rajapriya Pandian. She's an experienced embryologist, and she's a cluster head embryology Nova IVF Fertility, Tamil Nadu and Pondicherry. Her past positions were lab manager Nova IVF Fertility, Anna Nagar, and embryologist and IVF coordinator, Srishi Hospital. Her achievements: she's an S-ray certified senior clinical embryologist, S-ray certified clinical embryologist, and IFS certified embryologist. I don't have to tell all these things. She's a well-known embryologist. Her academics: MSc Medical Biotechnology, University of Westminster. Her special interest is advanced sperm selection, morphokinetics, and time lapse. Over to you, Rajpriya.
Thank you, ma'am. Thank you for the lovely introduction. Today we are going to we are having Soumya here from GG, and she's going to she's taken the topic of high DNA fragmentation index and the negative effects in the pregnancy outcome of ART. Soumya, are you there?
Yes,
Yeah.
ma'am.
To introduce her, she's currently embryologist at GG Fertility Research and Women's Fertility Specialty Center. She has co-authored and authored many presentations in international and national papers, as in ACE 2021, ACE 2022, ACE 2024, ISAR Embryology 2022, and in Embryo Milan 2022. And she's also presented posters. And Soumya, over to you.
Okay, thank you, ma'am. I'll share the screen.
This is a publication from GG Hospital itself. So Soumya is going to be presenting their own.
Thank you, ma'am, for the kind introduction. Okay, good evening, everyone. First of all, I would like to thank Tapisar team to give me this wonderful opportunity. As you can see, I'm going to speaking on sperm DNA fragmentation index and its effect on pregnancy outcome in ART cycles. So this journal is published in exclusive real world evidence journal. It is in the month of July to September 2024. And the primary author is Dr. Priya Shelvaraj, along with Thara Mahindra and GG team. And the primary fertility center is clinic is Fertility Research Center, GG Hospital. And the secondary clinic is Andrology Center, Coimbatore. And statistician contributed from Australian Center for Blood Disease, Alfred Hospital, Monash University. So as we all are aware of the influence of sperm DNA fragmentation and its outcomes in ART, and it remains a topic of ongoing debate. So the quality of the sperm and the integrity of the sperm chromatin identified as a sperm DNA fragmentation index it is an important indicator of the pregnancy outcome. What is sperm DNA fragmentation? It refers to single and double strand DNA breaks in sperms, and this DNA fragmentation index is used to quantify the extent of the damage. This high DNA affects fertilization, embryo quality, and implantations. To evaluate this SDF, we have so many assays nowadays. There is tunnel assay, Comet assay, and most popularly one is this SCD and SCSA. SCD means sperm chromatin dispersion test, and SCSA is sperm chromatin structural assay, which we have covered in this study. Going to this particular study, it is regarded as a gold standard for appraising sperm DNA fragmentation, and it generates a consistent DFI measurement. And this is highly regarded to specificity, accuracy, and predictive value. So more than 25%, it suggests lower pregnancy success rate. Somehow, if the patient conceives, there is a chance of higher pregnancy miscarriages. So miscarriages. And this is how the report is generated. And this is how it is categorized according to the percentage indices. So earlier, they used to call it as integrity, but now it is directly reflected as pregnancy outcomes. That is, if it is less than 15%, it is excellent to good pregnancy outcome. And if it is between 15 to 25%, it is categorized as good to fair pregnancy outcomes. And in between 25 to 40, it is fair to poor pregnancy outcomes. And if it is above 40%, it is very poor pregnancy outcomes. If the HTS level is more than 25%, it is detrimental for the embryos. And next, the study objective and the methodology. So to analyze the correlation between DF5% and the ART success is our objective, and it is done in GT Hospital, Fertility Research and Women's Specialty Center, and it is the duration period is January 2014 to 2018, and it is a retrospective single center study, and the population number is 941 patients recorded were assessed, and with 574 meeting the final criteria. So the inclusion criteria is available pregnancy delivery outcome and the complete ICSI cycle. And the exclusion criteria is ongoing pregnancies and cycle cancelled and incomplete data. So next, we'll go on to the procedure for SCSA analysis, which is done at the Andrology Center, Coimbatore. So when we send the samples, they used to, the cryopreserved samples were thawed at 37 degrees Celsius, and it is diluted with TNE buffer to approximately 1 to 2 into 10 raised to 6 sperm per ml, and it is stained with eccrine orange. And this is analyzed in flow cytometry, and the report is generated. Next to the study population distributions. So as I have already mentioned, the study population is 574 patients. Among this, 250 is positive pregnancy outcomes and 324 is negative pregnancy outcomes. And this 250 positive pregnancy outcomes, 153 gave live births and 97 gives this miscarriages. And the statistical analysis was performed using GraphPad Prism 6.0F as a software, and the Mann-Whitney U-test is used to assess the sperm parameters between groups with pregnancy outcomes, and Kruskal-Waltz test is used to evaluate variations in sperm DNA fragmentation index across groups, and the chi-square test is used to association between the sperm motility classification and the pregnancy outcomes. As we all know that significant level setup is at less than 0.05. So the two relevance, these are the parameters we checked for the pregnancy outcomes. First variable is sperm count. So in this sperm count, we use this box plot comparison of sperm count, and no significant difference in sperms count between these groups. The median sperm count is 50 million across all the groups, and the p-value for the pregnancy outcome is 0.523. And from that pregnancy outcome, that miscarriage and live birth is taken, the p-value is 0.885, so no significant difference. Next variable is the age. So here also no statistical significant difference between the groups. There is median age remains stable across the groups, and the p-value for the male is 0.768, and for the miscarriage and live birth it is 0.177. And for the female, the p-value is 0.165, and for the miscarriage and live birth, it is 0.506. Next variable is sperm motility versus pregnancy outcomes. So here, we have checked the normal motility versus asthenospermia. So here also no significant difference is found, and the graph is bar chart comparison of motility between positive and negative groups, and the p-value is 0.82. So, and next is the male versus female factor in ART outcomes. So patients classified based on the male and female factor in fertility, and no significant association found with ART success. And this p-value is 0.78. Next is the DF5% in negative versus positive pregnancy outcomes. So it is significantly higher DF5% in negative outcomes, and the p-value is 0.019, and the median for negative is 22, and the median value positive is 19%. And the next is the DF5% in live births versus miscarriage using Kruskal-Waltz test. So here also no significant difference in the percent DF5 between miscarriage and live birth, and the p-value is 0.063, and the median for negative is 22, and the median for miscarriage is 18% DF5, and the live birth is 19%. Next, finally, this is the last one, that is the HTS percent in ART success predictions. No significant difference in HTS values between the groups, And the p-value for is 0.45 for pregnancy outcomes and 0.615 for miscarriage versus live birth. And the study strength and limitations. Strength of the study is largest single center study in India, and standardized SCSA methodology used for the person DFI analysis, and is comprehensive statistical analysis performed. So limitations of the study is it is a retrospective design, and other sperm quality parameters not deeply explored, and limited generalizability to diverse populations. The summary of this study is it involved 574 patients, and fertility, it's the fertility predictors, and the sperm count and age not significantly influenced pregnancy outcomes, sperm motility, so no significant impact on outcomes, reinforcing that other factors like sperm morphology or genetics may play a greater role. So the DFI person, it correlated with negative outcomes. It is significantly statistically different, and the HDS percent show no significance, indicating that type of DNA damage assessed may be crucial. So findings highlight the multifactorial nature of the ART success and the clinical relevance of the person DFI in predicting pregnancy outcomes. So the key insight to overcome these high DFI is to make the lifestyle modifications, and in clinically antioxidant therapy, and in lab aspects, advanced sperm sorter techniques can be used to avoid the centrifugations which may cause higher, to make more damage to the sperms. And finally, SRMA. What is SRMA? SRMA retention motility assay. So for high DFI patients, could potentially help to evaluate how well sperm maintain motility over time. And we'll go in detail about this procedure. First, obtain a fresh semen sample or thaw preserved sample. Use centrifugation or swim-up method to isolate motile sperms, and place sperm in controlled conditions to mimic the physiological settings, and observe sperm at regular intervals for motility retention using microscopy or motility analyzer. And the formula for motility retention rate is number of motile sperms after incubation by number of motile sperms before incubation into 100. So sperms with high DFI show a low retention of motility. Example, less than 50%. It indicates that DNA fragmentation may be affecting the sperm's ability to maintain motility over time. So conclusion. So sperm count and age were not significant predictors of ART success. And DFI% showed a strong association with negative outcomes, highlighting its potential as a prognostic marker. In conclusion, I aim to contribute clinically. We have to treat these high DFI patients, and we are now doing the second phase of the study with medical interventions. That is, DFRAT tablet is given to the patients, and this is marketed by Shield itself. And in this study, we are getting better pregnancy outcomes, and it is a multi-center study. We can get good results. So this paper is yet to publish. Thank you.
That was a very elaborate presentation, Soumya, and congratulations to the DG team on the study. I see this is a retrospective study, and as the statistical analysis has shown, the sperm count, motility, and also the patient age and what kind of infertility doesn't matter when it comes to negative and positive, but the percentage of DNA fragmentation has definitely impacted the more negatives in this study. So rightly as put forth by the WHO, DFI has been coined as the extended sperm examination parameter, and also WHO has now stated that all our naming factors like oligo, astinode, any diagnostic parameter is completely waived off, but we still use it for clinical convenience. So any parameter in sperm to be clinically correlated, and then the treatment has to be given, is what WHO has also said. So this DNA fragmentation, obviously, like many clinicians, they say, okay, we have done IUI, the pregnancy is positive or miscarried or negative, and even in IVFs, the outcomes is not proper. So there's actually a very good diagnostic kind of spotlight showing that not just the count and motility is going to give a pregnancy for our patients. So as a diagnostic tool, this has given us a good insight to many of our clinicians that DNA fragmentation might also be the factor for having no pregnancy, or sometimes even miscarriages or abortions, even though it is not statistically significant in your study. But one thing I wanted to ask Soumya, this test what you have done is through an andrology source, right?
Yes.
So, how is the practicality of using the same technique in our regular labs? Because the SCD technique of DNA fragmentation is kind of very easier to find the DNA fragmentation percentage, right? DFI index. What is your experience about it?
Actually, we used to check all the parameters of the sperms, and we used to cryopreserve the sperms in the cryotank, and and we used to send it to the andrology center every 2 to 3 days, and they used to check and generate report, ma'am.
Okay, so the one advantage of the SCSA assay is that you get both the DFI fragmentation percentage and also the high DNA stainability, right?
Yes, high DNA
Okay,
stainability. Yes,
but
ma'am.
our study has apparently told that only the DNA fragmentation has impacted the negative percentage in our
Yes.
study cohort. When it comes to the high DNA stainability, it
Mm.
more or less kind of gives us an idea if there is a good packaging of DNA material in the head, and if there are, more immature sperms in the whole sample. So at the end of the day, the DFI fragmentation index, we could use any technique like tunnel or SCD or SCSA, right?
Yes, ma'am. Okay.
Okay, so that is one thing. And this SRMA also kind of it is something different what you have explained. It is
Yes.
similar to our sperm survival assay, isn't it? So when the culture conditions are ambient, we do this sperm survival assay on a regular basis in all our labs. So it is
Yes.
kind of
Right.
similar to it. And
Mm.
as you say, when the DNA fragmentation is higher, the potential of the sperm is also less. And so
Yes.
its motility decreases during the
Over time.
incubation time. So that is one a different thing. It could also be used in case the patient is not affordable and we want to just see if it is motile or not. We could do a SRMA on it. And one more thing about the sperm DNA fragmentation is, Soumya, we can use it as in this, because it's a retrospective study. It gives us a diagnostic insight. And my question was how we use it, but you have put it in your key points saying that we could use a good sperm selection assays, and also kind of use it for could you name a few assays which you use at your center or you recommend?
Actually, for fat to poor and very poor, we use to advanced sperm sorter techniques, ma'am, so that we can reduce the centrifugation. We generally use these two, Cymot or Lensuk is the examples we use.
Okay, so
They-
microfluidics, basically microfluidics
Yes.
chips you use. And
Yes.
one more thing is max is being explained in our WHO manual as well. So that is a sperm sorting technique they had resorted, but sometimes it could be expensive. But the concept in max is that you get to screen the apoptotic sperms from the non-apoptotic ones, and that also invariably kind of correlates with sperms with good DNA integrity, and also the mature sperms which has less HDS. So that also could be one option which could be used depending upon the availability. A center could choose using max. And also what about the hyaluron binding assay, Soumya? Have you used hyaluron binding assay to assess the sperm's
Yes,
integrity?
before we done the study, ma'am, with using the sperm slow and MFSS. Yeah, but now we are not using it right now.
Okay, because that also could be an option. Because when a sperm head binds to hyaluron, then it
Yes.
means that it is inherently mature and it has a good DNA integrity. So both microfluidics and hyaluron binding could also be an option to choose these sperms with high DNA fragmentation and to kind of increase our pregnancy outcomes and laboratory outcomes as a whole. Thank you, Soumya. Thank you for a lovely presentation. Vijaya ma'am,
Yeah,
your expert opinion on it, ma'am.
yeah, that was a nice presentation, nice study, study, Soumya, the GG study. And actually, DNA fragmentation, we all know basically it affects either the DNA fragmentation, it affects pregnancy, natural conception, IUA conception, IVF conception, and all the discussion, everything was good. And there are some studies which, when there is whether this is a normal looking sperm with DNA fragmentation in case of ICSI, or if it is an abnormal sperm with a normal DNA fragmentation, then there is no fragmentation, because when we select each sperm and that cohort of sperm, that particular sperm DNA fragmentation, we don't know, isn't it, Rajpriya? So how see, when you select the sperm, if it is going to be cryopreserved sperm, and I just wanted to know from Soumya, do you do that sperm fragmentation assay when you use that sperm, cryopreserved sperm?
Yes, ma'am. Cryopreserved sperm. Actually, not for the cryopreserved sperm. All the sperms we used to cryopreserve and send, ma'am. So all the tests we are doing is cryopreserved sperms only.
Because even cryopreservation will affect the fragmentation, isn't it? It can induce.
Actually, regarding SCSA, ma'am. So the thing is, the protocol that the andrology center asks is to basically flash freeze the semen sample and send. So actually for that, they did there's a large study which was published in 2022. In that they compared SCSA between fresh samples and frozen samples, actually, like this flash frozen technique and fresh samples, and they found that there was no significant difference there was no major difference in SCSA values actually. After that only this protocol was standardized for SCSA. Maybe for SPD and all that variation might be there, but this study was specifically for SCSA.
Basically, they don't centrifuge, no, Dr. Sindhuja. So they just flash freeze the sample, and that does not generate any ROS, ma'am.
Yeah,
so that's what the laboratory suggests. And one more thing I wanted to bring forward is that whatever the DNA fragmentation is, if the egg has the potential to correct the minor nicks and corrections in the DNA, then we have a good outcome. But when the egg itself is not proper, like when it comes to poor ovarian poor oocyte quality, nowadays we have poor oocyte quality not just in advanced maternal age patient, even young patients who come in, they end up having very poor oocyte morphology. And even if they have a good morphology, we end up having very less embryos, and fragile oocytes are seen in many PCO cohorts. So if the egg has the potential, and if there's only minor DNA fragmentation, that is also a correctable thing what the egg does. So at the end of the day, it's the egg and the sperm both that makes the baby, right? So
and what some the studies says is, in case of the DNA fragmentation, if some critical genes are affected, in paternal critical genes are affected, then the embryo, it may develop, but it can get arrested. That's what some studies are saying. Even with the DNA frag, so I think finally, as you said, oocyte has its own correcting the DNA.
Yes, ma'am. So I think maybe we should keep in mind that if it's a highly fragmented sperm and if it's a slightly older patient, it's better to go in for advanced sperm selection techniques so that we can confidently culture to blastocyst. Otherwise,
also maybe prior to taking them, just give them antioxidant, some therapies to improve the sperm quality also.
What about
Working very well, ma'am, but now it's not available.
what about one day, Sindhuja? What about one day abstinence and the second ejaculate on these patients?
Ma'am, definitely, ma'am, that also helps actually. And sometimes on the day of pickup also, we ask for a second ejaculate. If it's a very high DNA fragmented patient, then we ask for a second sample. So we ask them to come early, give one sample, and we use the second sample for ICSI with some sort of microfluidic technique, ma'am.
So would you still prefer an ejaculated or a testicular sample?
Ma'am, if it's very high DFI with microfluidics, if it has still resulted in poor blastulation and poor pregnancy outcome, then maybe for the subsequent cycle we can try TISA, ma'am. But with this, these parameters itself, I feel it is helping, ma'am. What's your take, Rajpriya, ma'am? Would you suggest TISA in the first cycle itself?
There has been studies that show there is no statistically significant difference for a testicular sperm and 0 days abstinence sperms, ma'am. So when it comes to high DFI patients, we generally keep a track of them, and especially if they are having ejaculatory difficulties, we can't ask them for a second sample on the same day. So we kind of ask them to, ejaculate a day after trigger, like just a day before pickup. If they ejaculate naturally, then we have 0 to 1 day abstinence, and those sperms have a better motility and lesser DNA fragmentation as per our experience, ma'am.
Okay. So do we make it as a routine? For example, a elderly male person, like anybody above 40 or something, or even above 35 with previous fail, can you make it as a routine, this DNA fragmentation index, or only in indicated patients we do?
If you feel if there is advanced maternal age in the advanced age in the male, and also when it comes to diabetes and all, ma'am, we generally correlate them having more DNA fragmentation. So it is not necessary to kind of do the test, but you could take the precautions of asking them to ejaculate the day before. But if they've already had a IVF cycle elsewhere, and they've not been successful, then a DNA fragmentation test could throw us a light on how this could have happened. So in that case, we can firmly say that they could be helped with advanced sperm selection techniques, ma'am.
Even suppose they have a high DFI and you give them some antioxidants, and would you like to repeat the DFI, or we just go ahead with the treatment?
Antioxidant treatment, there are many studies wherein there is like 3-month antioxidant treatment given to that particular patient. But if the DNA fragmentation is too high, like for example beyond our index, there's not much variation, ma'am. There's not much decrease, hardly 5 to 6% decrease we see in the DNA fragmentation. So empirically, antioxidants help reduce, but not to a great extent. But we can also suggest advanced sperm selection technique when they come for IVF, ma'am.
What about any treatment like varicocele and other things? Because we know it is already a controversial one. But does it have an impact on the DFI level? Suppose high DFI, whether we could go ahead with the failed IVFs and failed fertilization or something, where this could be one of the factors. There's an evidence support.
Grade 4, definitely, if you go in for surgery, it definitely improves the DFI, ma'am. But for minimal and mild grades of varicocele, the surgery does not really improve the DFI, ma'am. So there can be other reasons also why it is being caused. But repeatedly, if the patient with a minimal or mild is still having high DFI and poor outcomes, then the urologist decides whether it is required or not.
When these samples are frozen and taken for tested, the DFI, does it have an effect on the levels?
That's what, ma'am. So in 2022, there was an article, ma'am, which said that for SCSA specifically, when we are flash freezing and comparing the flash frozen sample and the fresh sample, there is no significant difference in the DFI values from SCSA. From other methods of DFI, we can't really. But for SCSA, there is no difference, ma'am.
Most of us, we freeze the sample after processing it, ma'am. So for SCSA, they recommend flash freezing. That is, no centrifugation is necessary for that. But generally, if we see, most of our labs use the ready-made kits which use the SCD technique, ma'am. In that SCD technique, we would prefer using a fresh sample for a DNA test rather than a frozen sample, because obviously we have centrifuged or processed the sample and it could show variations.
Can we wind up?
Because, yes,
Yes, Sindhu. Yes, go ahead.
No, ma'am, only because SCD is more subjective. There's a lot of subjective variation. That's why I think people are moving towards SCSA now. And also because it is having more correlation with 7 parameters and age, and it is more reliable. I think that's why everyone's moving to SCSA now, ma'am, over SCD.
The reliability is more.
Okay.
Yes, ma'am. Thank you, Vijaya ma'am, Rajpriya ma'am, and Soumya for presenting. I request Kundavi ma'am to give the vote of thanks.
Yeah, thank you for this lovely webinar. I think it's really becoming very popular because of Sindhu, I think, choosing the topic, choosing the speakers. So I thank Dr. Sharad sir, the president, and Dr. Radha, the secretary, for being with us with the Journal Club. And special thanks to the chairperson, Dr. Aishwarya and Dr. Vijaya Ganesh, and the speakers, Dr. Danya from Aplu and Dr. Sumna Manohar being an expert. And lovely topics today. And Dr. Rajpriya Pandian and Soumya from GT Hospital for giving us, and good discussions as well, because I think it's very good topic, practical topics, I think, which is really needed for the clinician as well as for the embryologist. And thank you once again for all the delegates who've been with us. And thanks, Shield, for giving us the platform, online platform. Thank you so much. And thanks, Sindhu. We'll meet probably on Sunday.
Yes, ma'am.
Thank you, ma'am. Thank you, Dr.
Thank you.
Sindhu.
Thank you, Sindhu. Thank you, Rajpriya.
Thank you, Vijaya ma'am. Thank you.